continue our introduction to pathophysiology of immune system, and we in previous session finished with classification of immune disorders. We do not pretend that this is the precise classification, but it is pathophysiologically in terms of showing that immune response may become overactive, resulting in hypersensitivity reactions, which include allergy, autoimmune disorders and diseases, and transplant rejection. From the opposite side, insufficient immune response may result in immune deficiency syndrome, which could later be classified into impairments in adaptive and innate immune response. We start with hypersensitivity reactions, being defined as a abnormal form of immunological reactivity, which is characterized by a specific overactive response to an antigen, which leads to self-normal cells and tissue damage. Actually, sometimes it's difficult to have a good line between normal immune response and maladaptive and hypersensitive, but probably the main point that once we mentioned about Allergic was that immune system was considered, normal immune system was considered as magic bullet that is able to destroy only the pathogen, leaving as much as possible our self tissues intact. Of course, there is some accompanying damage always, but if the main thing that we have is the damage to self cells, then it is hypersensitivity. In Soviet tradition, there is such subdivision of the process into 3 stages: immunological, or stage of sensibilization, which begins from the first exposure to the allergen, as we call it in allergies, or an antigen, and until the second exposure with the same antigen and formation of antigen-antibody complex, or in some cases antigen T-cell complex, which is followed by production of mediators, and that's why the name of the stage is pathochemical stage. Here we have release of various mediators of allergy, which is without specific line continued to pathophysiological stage, or stage of clinical presentation. That could be edema, that could be bronchospasm, or in most dangerous case it is accompanied by systemic reactions like systemic anaphylaxis with severe reduction of blood pressure due to vasodilation and distributary shock. So let us first classify these hypersensitivity reactions. It is for about 50 years or so since Gums and Gel classified hypersensitivity reaction depending on their mechanism into 4 types. First 3 are B-cell dependent, and the last one is T-cell dependent, and again the first 3 are immediate. This immediate response we should consider not after the first exposure, but in all cases when we are talking immediate or delayed, it is about how much time is spent after exposure to the allergen second time. And in case of immediate response, it happens within seconds, even sometimes 2 minutes, and then hours for B-cell dependent response. When T-cell dependent type 4 hypersensitivity typically lasts more than a day, usually 48 hours or so. Here different synonyms are given for each of the types, and we start with type 1 hypersensitivity, and we should go through this picture twice from allergen. First exposure, we should go down here when allergen is entering the body. It is separate tissue, white. Why should it come in? Is it always from outside or what? But importantly, dendritic cell is capturing this allergen and it's deciding to express this allergen on its MHC class II molecules. It is also a moment of decision, and it is also a moment of genetic susceptibility, why some becomes allergic and the other not. Also depends on his MHC class II molecule subtype polymorphism. Anyway, after this presentation, T helper is, as we already mentioned, importantly choosing Th2 pathway, and here are its key cytokines: interleukin 4, 5, 9, 13, but most important interleukin 4, which not only is triggering humoral immune response, but also switching production of immunoglobulins from M not to G but to IgE. And the result is that these immunoglobulins, they are usually not circulating in blood plasma. You can find they are very low amount compared to G immunoglobulins. Instead, they go and find their perfect receptors on mast cells, which, as we remember from Ashot Koryunovich, probably Ishizaka brothers counted the number of receptors on mast cells for IgEs, high affinity receptors, as we say, which make them #1 target for IgEs, and they found that there are so many receptors for IgEs, which makes us think that these immunoglobulins were made specifically for mast cells. And after this, they may quite a long time, for weeks, maybe months, stay bound on the surface of mast cells and wait for second exposure to allergen. Maybe it will happen never, but most probably if something happens once, there is very high probability of happening it again. And before this moment, we are still in the stage of immunological reactions. When these immunoglobulins are located on mast cell, we may say that the person is already sensibilized to given allergen. So when there would be a second exposure to allergen, then it is binding to Fab fragment of IgEs, typically onto neighboring ones, as we will see on the next slide, which triggers release of various mediators into work, and this is pathochemical stage now, which usually also recruits eosinophils and later neutrophils into the process, and we have very active bout of inflammatory response at the site, as well as, for example, shown here, wheezing, urticaria, sneezing, rhinorrhea, conjunctivitis. It really depends on where this is taking place. And then we will have also the second stage when the other mediators will come into the work. They would include those products of eosinophils like basic proteins, leukotrienes, platelet activating factors. Usually these are weapons that eosinophils are utilizing in order to destroy helminths. But unfortunately nowadays it works not against helminths but our self cells. And we may have therefore some 48 hours later, or probably 24 to 28 hours later, chronic allergic reaction. Chronic stage of the response, and then it may turn into sustained symptoms if the contact with allergen is continued. This picture also shows the same events, with some episodes are shown here better. First, it is shown that antigen is binding two neighboring immunoglobulins, immunoglobulins together, which were attached with Fc receptor. This results in intracellular signalization for degranulation, which is usually calcium mediated, and it results not only degranulation of already prepared substances like histamine, proteases, chemotactic factors, for eosinophils, for neutrophils, etc., but also release of activation of phospholipase A2, which results in formation of new mediators, out of which are NOD40 PAF, extremely active in terms of increasing permeability, as well as arachidonic acid with resulting prostaglandin D2 formation, and glucotrienes B4, C4, and D4, which are together called slowly reacting substances of anaphylaxis, since they mimic the effects of histamine, but they are much more stable in their effect, and they are broken down less actively than histamine by histaminase. And here we see also the immediate versus late phase reactions, which by overall their direction are similar, but in this case we have much more leukocyte infiltration and the continued damage to the tissues. So here is some generalization of most important events in the text. We can see here also mast cells, how they degranulate. We see how extensive is this process, 5 seconds and even 60 seconds after exposure, fully degranulating mast cell. This slide is very important in terms of making us to think about why question. Finally, why this or that allergen becomes antigen becomes really allergen. There is really genetic predisposition to different kinds of atopies. The most common forms of these allergic reactions, like atopic bronchial asthma. This could be due to specific polymorphisms in HLA alleles, at production of interleukin-4 could be, which was driving the response into the type 1 hypersensitivity. Interestingly, we have environmental factors, so many allergens that we have now in the everyday life, which was probably not true maybe thousands of years ago, but now we can enter to each of our supermarkets, as Chulila and Zajcik mentioned in their book. We can find antigens made in all the different countries in the world. All are available right here, but we shouldn't be exposed to so many antigens. So probably this is also of effect, or it is noteworthy excessive hygiene as a environmental factor. Of course, this is yet disputable. Could it be like excessive hygiene as a risk factor for developing atopy? But there is some point, is if this kind of immune mechanisms were made in order to fight helminths, what if we now keep our hygiene in such a level that we do not allow any helminth to enter our body? So the result could be utilization of the same mechanisms against anything else. So probably our T helper 2 cells are hungry for doing at least something. The other possible factors are shown. Maybe we have defect in target organs, maybe we have defects in this epithelium which are increasingly permeable to some products, and also triggers are shown. In case of bronchial asthma, the result would be a bronchospasm, inflammatory response here. Triggers and inducers are also shown here, and all of this finally result in limitation of airflow, bronchiolospasm much severe, and typical presentation of asthmatic patient. The other reactions for type 2 hypersensitivity, as we mentioned already, include anaphylaxis, include allergic conjunctivitis, urticaria, and some other examples later in the table we'll see. Let's move to type 2 hypersensitivity. Here antigens are not coming from outside as it was in the previous case usually, but they are here within our cells, more precisely at the surface of our cells, or as a variant of this, from outside a hapten could come, means small, usually non-immunogenic particle, and when it binds to our cell proteins or cell surface, together they become something unknown and non-familiar for our immune system. Therefore, it results in triggering of humoral immune response with IgGs and IgMs. An example includes different types of cytopenias, like in this case we have antigen on our red blood cell membrane. Normal G and M immunoglobulins, mainly G immunoglobulins, are produced here, binding to these antigens, which results in both opsonization and phagocytosis, as well as activation of complement system, which eventually leads to cell lysis, both antibody-dependent opsonization and C3b dependent. The same we see on this slide, how G immunoglobulins, here they are binding to this antigen and through the Fc receptor, as well as complement system activated, again serves as opsonin, and these two opsonins work perfect to stimulate phagocytosis of the target cell. Similar consequences we might have also by activating inflammation, not just phagocytosis. If it was a cell in a circulation, that would be quite enough for red blood cell. But if the target cell is deep in our tissues, it may continue to production of various components of complement system, like C5a, C3a, together this known as anaphylatoxins, which trigger very active inflammatory response with continued release of reactive oxygen species, proteases, and finally damage to the tissue. But interestingly, third thing also is present here is a third variant possible, when antibodies do not destroy the target cell or trigger inflammation, but have some specific influence. They may cause dysfunction in the tissue. One such example is antibodies produced against thyroid stimulating hormone. The result could be activation of this cell, and since thyroid stimulating hormone was doing stimulation of thyroid hormone production, the result clinically would be hyperthyroidism, and actually this is probably the most important point in pathogenesis of Graves' disease, when we have so-called long-acting thyroid stimulators that they are antibodies. Why they are not just destroying these cells, why they are activating. This is rare, I think, within the immune system in general, but as a disease may be rare, but as overall regulation we could expect this. An opposite situation we have in another disease called myasthenia gravis. In this case, again, we have antibodies against our self-antigens, which are, interestingly, receptors for acetylcholine. Interestingly, they do not activate this receptor. Instead, they are just blocking it. And as a result, acetylcholine, when released, is not finding appropriate amount of its receptor to activate the muscle, so that it is clinically manifested as muscle weakness, which is the hallmark of myasthenia gravis. So both these specific examples are within the type 2 hypersensitivity reactions. We move to type 3 reaction. Here the problem is formation of immune complexes, sometimes referred as toxic immune complexes. Since the most important feature of this is that antigen-antibody complexes, even normally, could be formed in blood circulation, but then they are normally removed from circulation by help of neutrophils, phagocytes, and other receptors who are able to recognize Fc receptors, and an immune complex is removed from the circulation. Here, due to some reason, it is not happening, either due to specific structure or maybe due to a specific size of the complex or charge, and the result is that not removed complexes circulate a little, and then they deposit into the tissue, where they result in stimulation of inflammatory response, of inflammation. Here we see how neutrophils come and participate, complement system, and actually develops into a vasculitis. which, of course, depending on where this issue happens, where this event happens, may have different clinical manifestations, like if one of common sites where immune complexes like to reside, glomeruli of the kidney, and the result is one of subtypes of glomerulonephritis. Then, after these three types, we now move to cell-mediated immune response, type 4, delayed immune reaction, and here it depends on two types of T cells, either CD4 plus helpers or CD8 plus killers. Both could lead to damage in our cell tissues. In one case, it is through CD4 cells, as we mentioned, which promote inflammatory damage to the cells, mainly through production of various kind of cytokines, chemokines, which invite neutrophils and monocytes to the site of the damage, and they result in destruction of this tissue. It is suggested to be most important mechanism in type 1 diabetes mellitus. And especially it's important to mention that this kind of helpers are usually TL1 or much commonly 17. It is its loved function to promote inflammation and damage to our tissues. While in the next scenario we have, which would be again the case here, through mainly participation of CD8 plus cells, means cytotoxic T cells, which already themselves, by having specific T cell receptor against self antigens, and they destroy our tissues. The prototypical example is contact dermatitis, which happens in response to poison ivy. And here it is how it is usually presented, and we continue with a table which is divided into two slides, which is perfect in terms of generalizing and repeating which kind of reactions we just mentioned, or what are most important mediators of each of them, which are B cell, which are T cell dependent, what kind of helper cells we have. As we mentioned, helper 2 crucial for type 1, helper 1 and 17 for type 4, while usual helper 1 for 2 and 3 type. And other important facts, as well as antibodies once more mentioned, shown that complement system involved probably in all of them, but specifically important in type 2 and type 3 hypersensitivity reactions, and typical examples are also given here. So we finished this portion of hypersensitivity reaction. Reactions. Just got to conclude that hypersensitivity reactions include not only classical allergy, which is usually limited to type 1 hypersensitivity, except of some specific cases. Type 2 is the main hypersensitivity pathway for autoimmune disorders, but they may also be found in type 3, like that is for some kinds of glomerulonephritis or lupus erythematosus, which is again autoimmune disorder. And type 4 reactions, both could be a way for autoimmune reactions as well as some anti-infectious reactions, like prototypical is anti-tuberculin reaction. And now we move to immune deficiency syndromes. We will only shortly review them, because we of course recommend you to read more about it, and the main aim of this lecture was not to give you specific syndromes about them, they are perfectly described, but to provide some explanation only. I want to focus your attention on, maybe it is oversimplification, but Uh, we might say that if the main uh, problem in immune system is within humoral immune response, as a rule we have a problem of fight with bacterial infections, while when the main problem is in cell-mediated immune responses, we have much more viral and fungal infections. This is simplification, of course, but there is more or less such relationship. All of these immune deficiencies are characterized by recurrent infections, different types depending on what kind of immune deficiency it is. Some immune deficiencies which were due to innate immune disorders we discussed when we were talking about inflammation, those which were about problems in neutrophil killing mechanisms, myeloperoxidase deficiency, etc. And here, therefore, we will go only through acquired immune deficiency, acquired immune response or adaptive immune response problems. They could be classified as mainly B cell defects and T cell defects. Prototypical is for T cell like DiGeorge syndrome, while for B cells it is usually Bruton's gamma globulinemia. Or we might have combined defects, both T and B systems affected. On the next slide we'll see where is usual molecular defect in each of them. And we might have also not inherited or congenital, but secondary deficiencies acquired. Please do not confuse, as I did seconds ago, acquired immune response and adaptive immune response. And here we may have secondary deficiency or acquired deficiency of acquired immune response. So it could be due to starvation, deficiency of proteins in the food, some drugs like glucocorticoids. The classical example is viral induced secondary deficiency called acquired immune deficiency syndrome, as well as different chronic bacterial infections finally may lead to this. Many chronic diseases lead to more or less deficiency in immune system like diabetes, different malignancies, Cushing disease due to overproduction of glucocorticoids which have immunosuppressive effect. And here you can see for hereditary cases of immune deficiencies, more than 120 to my knowledge are now described, and here you can see where is defect in each of these cases, like for the cells still in bone marrow, if they have deficiency in adenine deaminase enzyme, the result is accumulation of some toxic metabolites which impair both T and B cell systems. Probably a little more for toxic for T cells is believed to be. For B subsystem, most commonly we talk about X-linked disorder of X-linked gamma globulinemia, where we have problem in Bruton's tyrosine kinase gene, which results in impairment in the maturation. The problem in DiGeorge syndrome, as well as in severe combined immune deficiency, is affecting much more T cell subsystem. In this case, in severe combined immune deficiency, the problem is in common cytokine receptor gamma chain, and the result is that the T cells cannot get corresponding activation. Like, for example, they cannot become activated by interleukin-2. A few words about X-linked gamma globulinemia and some others. We may see that the maturation of B cell is not so easy, of course, process. In this case, we have failure of B cell precursors to develop into mature B cells, and here where the defect is Bruton's tyrosine kinase is mutated so that B cells do not maturate, and that's why we have germinal centers of lymph nodes, Peyer's patches, appendix tonsils, or all are underdeveloped, and therefore plasma cells are absent throughout the body, while T-cell mediated reactions could be normal. And it's important to see that, of course, that there is no such strict rule that if you have this immune deficiency, necessarily, specifically this or that bacteria should cause some problem. But there is some rule, and that's why this table is shown here. Like if in our case we are looking for B-cell defect in Bruton's gamma-globulinemia, most common bacteria are here: streptococci, staphylococci, haemophilus influenza. Some viruses could be there. Out of parasites, nonetheless, with the other, interestingly, with other fungi and parasites, T cells would fight properly. But against intestinal Giardia, Lamblia, here is this pathogen, we require B cells, and that's why out of many possible parasites, B cell defect results in problem in this parasite. And here are those scientists whose family names give name to this interesting parasite, Giardia lamblia. Okay, about other causes of immune deficiency, I hope we will have chance to discuss in practical classes. And now let's move a few words about the tolerance, which is crucial for understanding of autoimmunity and autoimmune diseases. So, when T cells migrate to thymus, which is believed to be the school for T cells, here is very important process of self versus not self differentiation. All the initial T cells which come here to thymus show their T cell receptors, and local antigen presenting cells are showing them their self-peptide. If they react, means they have receptors against self. So usually these clones are forbidden, and therefore they are deleted. Through apoptosis they are removed. Probably most of such cells are removed at the moment. But interestingly, some of these cells, and according to some sources and authors, especially those which are very which have very high affinity receptor against self antigen, they become regulatory T cells later, and then these cells become very important for induction of peripheral tolerance, about which we'll later talk in more details. While those which do not express self-reactive clones, here they will be important in normal immunity later on. Unfortunately, or fortunately, not all the antigens we can show in the thymus. Especially there are some antigens which are not present in thymus, or they are in some immunoprivileged organs like in nervous system, in the eye tissue, in gonads. So it means that central tolerance cannot be responsible for all autoimmunity, for all tolerance, sorry. And that's why some self-reactive clones leave thymus, and their destiny is depending now on future contacts with self-antigens. There are three pathways how they may be inhibited. One is the emphasizing important role of deficiency of co-stimulation. Here is our tissue cell which is lacking B7 co-stimulatory molecule, and that's why the result is that when the antigen is shown, it is recognized, but there is no co-stimulation. Usually it results in so-called allergic. Means this lymphocyte is not killed or destroyed, especially if it is our tissue cell, not anything dangerous. But usually they lose their activity and they become allergic. Another variant, if there is co-stimulation and there is responding to the self-antigen which is being presented by antigen presenting cell at the periphery, the result is so-called activation-induced cell death, apoptosis. So it is like punished for showing self-antigen reacting T receptor. And the most probably intriguing during the last years is the way how regulatory T cell is preventing reaction against cell tissues. We'll talk now about how regulatory T cell does this, but here just I wanted to show that it is not always so bad if the self-reactive lymphocyte appears. Yes, one, of course, destiny is just to induce deletion of that cell clone through apoptosis. For example, most commonly through inhibition of BCL2 pathway. But importantly, there is another chance or opportunity. Their receptors may be edited. We may edit a little bit through hypermutation or recombination, and so that the self-reactive lymphocyte will become not self-reacting, as well as there could be intrinsic or extrinsic regulations which would additionally result in limiting its activity and suppressing activity of that lymphocyte. Most commonly it involves such change at the transduction mechanisms through ubiquitination within the transduction mechanism, that this cell is losing its potential to kill, becomes impotent. And finally, about the ways how regulatory T cell is able to induce peripheral tolerance. Four possible mechanisms are usually discussed. One, most easy, is through production of immunosuppressory cytokines. Of course, there is limitation to say how they do this only locally, not systemically, but most probably it is very important to have paracrine effect here at the site. Second group is through targeting dendritic cell, and so there is dendritic cell mediated immunosuppressive effect. The most dangerous way, if nothing else helps and if this self-reacting lymphocyte is too difficult to understand that this is cell tissue, then through granzymes, PNA and perforins, T regulator is able to destroy the potentially bad T cell. And it's important that the same T regulator is, don't forget that it is just subtype of T helper, so it is CD4 cell plus additionally CD25. And it is, yes, having weapons of cytotoxic T cells. That is really interesting. And the most interesting mechanism for me is metabolic disruption of the potentially dangerous effector T cell, one of which is through expression of CD25, because it is very high affinity receptor for interleukin-2. It's a high level of expression of this receptor results in so much utilization of interleukin-2 that effector T cells become deprived of this cytokine and undergo either long-term inhibition or apoptosis, much commonly. So after all, I just paid attention to those slides which I think required more explanation, and the final thing to do this is now from tolerance to move to autoimmune diseases. But before listing them and mentioning a few words about each of them, I think it's important to mention that when we can say that one or another disease is autoimmune. And there are three such indicators, which are not always to find each of them, but anyway. First is the proof that there is specific immune reaction against self-antigen or self-tissue. But that is not enough, because sometimes if only our tissue is damaged and due to this we have production of some autoantibodies, this is not yet autoimmune disease. Probably this is normal clearing process of damaged tissues and cells, just removal of unnecessary or damaged tissues. That's why we should prove that immune reaction is primary to the damage, not secondary. And third, if we do not find any other well-defined cause of the disease. If nothing else fits, then probably this is autoimmune. And here is the list of most common autoimmune diseases, and I think it is also correct to call them immune-mediated inflammatory diseases, which are classified depending on predominantly what kind of immune response is involved here. It is antibody-mediated or T-cell mediated. Each of them could be organ-specific autoimmune disease like autoimmune hemolytic anemia, thrombocytopenia, myasthenia gravis and Graves' disease mentioned, or Goodpasture syndrome involving at the same time two specific organs, lungs and kidneys, or systemic like the classic prototypical autoimmune disease, systemic lupus erythematosus. In some cases, the diseases could be caused by reactions to microbial antigens like polyarteritis nodosa. Among those which are mediated mainly by the T cells, we have type 1 diabetes mellitus, multiple sclerosis, which we'll discuss in next term, systemic autoimmune diseases like rheumatoid arthritis, systemic sclerosis, Sjogren's syndrome, and important to mention that antibodies also have some role here, not only T cells. And diseases caused by autoimmunity or by reactions to microbial antigens include inflammatory bowel disease, including Crohn's disease, ulcerative colitis, or inflammatory myopathies. Thank you very much for your attention.